Hey guys, so quick talk today. We're going to talk about cystic fibrosis, specifically as it relates to malnutrition and the CF gut. Brief overview. As you know, cystic fibrosis is an autosomal recessive condition. It is the most common cause of exocrine pancreatic insufficiency in children. And the mutations for this disease occur on a single gene in chromosome 7. And this gene encodes CFTR protein. And in order for someone to have clinical disease, it is required that they would have disease-causing mutations on both copies of CFTR gene. So what is CFTR? It's a regulated chloride channel, and it regulates the activity of other channels and also regulates the excretion of bicarbonate. And this is happening specifically at the apical surface of epithelial cells. So in order to just give you a brief characterization, this is what a normal CFTR looks like on the left-hand side, with chloride ions going across the epithelial membrane with no problems. Whereas if you have a mutant CFTR, which is on this side here on the right, you will see that that gate is completely closed and therefore no ions are being transported. And this leads to accumulation of thick mucus in different epithelial organs. So what does that mean for nutrition? As you know, our energy balance consists of balancing between surplus and deficits. And we know that individuals with cystic fibrosis can be at higher risk for an energy deficit. But why is that? So we have multiple factors. First one is having increased energy expenditure, lung disease, chronic cough, respiratory difficulties. Of course, we have cystic fibrosis-related diabetes as an important contributor to increased energy expenditure, and perhaps the CFTR deficit itself can be playing a role. Additionally, we have reduced absorption of nutrients, and that's because of a combination of pancreatic insufficiency and CF gut, which we'll talk about in just a moment. And then we have inadequate intake due to loss of appetite, reflux, or psychosocial risk factors. So the CF gut. So in order for us to understand how to care for patients with cystic fibrosis, it's very important to know that their GI disease, whether it was from pathophysiology or phenotype, extends well beyond the pancreas only. And that's really related to two main things. One is that the CFTR protein is heavily expressed in the GI tract, and it also functions as a bicarbonate channel. And as you know, bicarbonate is required to be present in the GI tract, particularly in the proximal GI tract, as we are trying to neutralize the gastric acid and create an alkaline environment for proper absorption of nutrients. So what does that look like? The vicious cycle of the CF gut is really very similar to this cycle of CF lung. So it starts with obstruction because, again, we have thick, dehydrated secretions. This triggers an inflammatory response in the epithelium and is usually complicated by an infection, which worsens the obstruction, the inflammation, and the cycle keeps on going. So a little bit more about the CF gut. So we're starting to think about the pathophysiology and how things start, and we'll end up with the phenotype and what does it look like. So we start with dehydrated, acidic luminal secretions. Again, they're dehydrated because there's nothing going across the cell surface because of the mutant CFTR. They're acidic because specifically bicarbonate is unable to go across the cell surface. There's malabsorption, and there's inflammation. So again, that obstruction, inflammation cycle. So what does that then lead to? So the other layer of problems then is the impairment in pancreatic secretions, which is again related to the thickening of all the secretions, the impairment in biliary function, which we know that you do need optimal biliary function in order to optimize absorption through the proper formation of micelles, and then you'll have viscous mucus that contributes to and worsens the inflammation. So what does that phenotype then look like? We will have then either pancreatic insufficiency, and that's the vast majority of patients. Those with pancreatic sufficiency are at very high risk of pancreatitis. Additional phenotypical problems then include cholestasis, steatosis, and poor micelle formation. And finally, and this is a very important component of the phenotype, we have dysbiosis or small bowel bacterial overgrowth. We have impairment in immunoglobulin A secretion and impairment in motility. So as a gastroenterologist, when you are caring for individuals with cystic fibrosis, you want to keep in mind all of these different complexities that are happening in the GI tract, and also remember that these complexities are occurring in the context of a global system that's affected by cystic fibrosis, as it affects virtually every organ system. And you will have to understand the medication effect on the GI tract, particularly when it relates to recurrent use of antibiotics, and also now the very new CFTR modulator types of medications. That's it. Thank you.